many of you know myself. I'm Susan Muirhead, the Support Manager here at PKD Charity. I'm joined tonight also by Alison Taylor, our CEO. Good evening, Alison.
Good evening, nice to see you all.
And also we have Dr. Yuki Heath, and Yuki is a speciality doctor in renal medicine down in Birmingham University Hospital. So thank you once again for coming to give a presentation. I think it was only of January this year when we had you talking about something else. So I appreciate your time tonight, Yuki.
Thank you for having me. Hello, everyone.
So tonight we have the meeting in a webinar format. So with that, you're in what we call a listen only and view only mode. So you'll be able to see myself, Alison and Yuki when we're speaking. And when Yuki gives her presentation, you'll be able to see her slides. However, if you wish to ask any questions, which will be asked after the presentation, you'll see there's a little icon, a speech bubble almost at the bottom of your screen that says Q&A. If you click on that button, it opens out a little screen, and in that you can type your question. Now, Alison and I will be looking through that as the evening goes on, and we'll be able to ask your question when the formal presentation's over. This session will be recorded and published on our website. And if you have any questions or queries, please do reach out to ourselves, either to my direct email or at our info@pkdcharity.org.uk email address. As much as we do have a doctor in the house tonight, I do have to give our medical disclaimer. This webinar is for information only, and we cannot substitute any professional medical advice or a medical examination. As always, consult your own doctor, pharmacist, or another medical professional if you are looking for anything to do with your care, or before starting or even stopping any of your medical treatments as prescription. And we cannot promote or recommend any treatments or brands. You may have become a fan of ourselves in these lovely sessions. They're so informative, and the feedback we get from them is great. So our next up and coming topic is going to be low clearance clinic. So when our kidneys get a little bit poorly, our appointments may become more frequent. It can become a little bit frightening because you're told you're going to go to low kidney function clinic, or low clearance, some of you may refer to it as. So we've got a lovely nurse practitioner coming along, and she will talk about what happens at these clinical appointments and which members of the team you might meet. Alison, can you pop that into the chat just for people if they want to register? You can scan the QR code or find more information on our website. What I'd like to do now, I'll just hand you over to Dr. Yuki Heath, who'll continue with the presentation, then we'll move to the Q&A thereafter. Yuki.
Okay, thank you. Hello, everyone. Thank you for having me. I'm Dr. Yuki Heath. So today's topic is PKD and kidney-related infection in patients with PKD. And this is slides taken from the PKD Charity site. There are 7 major symptoms in patients with PKD. And out of these, the next one, click, those 2, the next, so reduced kidney function and high blood pressure are very, very well known to any kidney doctors. But the other than 2, those 5 are quite not well known. And you can see kidney pain and infection without stone. And I talked about pain, in January. So today I'm going to talk about infection. Yeah, next slide. So when I say kidney-related infection, next slide. So how common do you think? So usually you say about half. So half the patients with PKD can get this kidney-related infection. So it's really common. And of course, without PKD, this UTI is really common. It said like 30 to 50%. So kidney-related infection, what are they? So I'm going to talk about what I'm talking about when I say kidney-related infection. So first one, UTI. UTI is urinary tract infection. Sorry, I'm just going to remove it's just this. Yeah, so first one is, just gonna see. So you can see bladder infection. And the bladder infection is just only in the bladder. So when the bacteria gets to the urethra, to the bladder, if that infection happens, we call it bladder infection, cystitis. So usually the symptom is only simply pain on weeing or cloudy urine or dysuria or frequency, and usually no fever. But if you can't get rid of this cystitis, the bacteria always thrive to get you. So they go into the tube, ureter, and the kidney. When that bacteria gets to the kidney, that we call it pyelonephritis. Then you have a pain, spike in temperature. So it's quite different from the bladder infection. Only to get to the solid organ, which is the kidney, this is urinary tract infection. You have a fever, spike in fever, and pain. The next one is both UTI and cyst. And if the cyst, some cysts, out of many cysts, communicated to the ureter, so the UTI can get to the cyst. And a cyst infection only can get to the ureter also. So both UTI and cyst, if together, again, you have a pain and a fever, spike in temperature. And then another one is, next one, cyst infection only. So sometimes cyst can get infection spontaneously, and that cyst, if that cyst does not communicate it to the ureter, you don't have any urine infection symptoms. So urine culture, nothing but cyst infection there. So that is a little bit tricky. And then next slide, this can cause pain again and the fever. So basically pain and the fever, and you can't differentiate really well. But cyst infection is quite difficult to prevent because we don't know how it happens. Next. So usually we think cyst infection happen, next one, by a blood flow or gut bacteria translocation. We don't know. So this is quite tricky to, sorry, can go back? Can you go back? Not this one. Yeah. So, but cyst infection can happen if you had a past history of a cyst infection, or if your cyst is quite big, like a 5 centimeter or bigger in diameter, you're a little bit high risk. But this is relatively rare, like 1% per year. But this UTI, both UTI and cyst, is quite common, 30 to 50%. So that's what I want to really prevent because this is preventable. Cyst infection is quite difficult. Yeah, next one. But again, sorry, pain only without temperature usually is a bleed. So you don't have to come to A&E. But if you have a pain, sudden pain and spike in temperature, you need antibiotics. And if you are immunosuppressed patient, if you have a liver transplant maybe or kidney transplant, you are immunosuppressed and you might not have particular spike in temperature or pain. In that case, sometimes some people don't have any spike in temperature pain, and then they keep having bad UTI or pyelonephritis, and then some people are really worried about how can I know? And I'm not particularly proactively recommending this, but some people are really worried and they want to know how can I detect? In that case, you can get urine dip stick over the counter. And then if you dip the urine, and if you look at all the first 2 sections, can you click? Yeah, so first 2 sections, leukocytes and nitrites. If those yellow color one go into the right side, like a dark purple and this color, together with those 2, that means you have an infection. But I don't really particularly proactively recommend this. And of course, if you haven't got symptoms, you don't usually have problem. But some immunosuppressed patients have got problem and then causing trouble, sepsis. In that case, maybe there is a way of this. Yeah, next one. Yeah, sorry. Yeah. So nitrate is very important. Yeah, next. Next, please. Yeah. So how do you get urine infection? So I really want to prevent urine infection. Yeah, next one. Yeah, where bacteria comes from. I always ask the patient who has got a UTI a lot, cyst infection a lot, together with UTI. And not many people can say clearly. It's a very common sense, but actually where bacteria comes from, is that come from somewhere in the air, but actually from the anus, your own anus. So that is a very important point. And next one. So why patients with ADPKD get UTI more easily? A little bit more easily because, yeah, next one. Bacteria can thrive in this particular group. There's a stagnant of urine elements. I will come on to that. Next one. So before I go to prevention, how clean each part of your body? I want to just go through that. So in the small pelvic area, there are 3 systems. First one, digestive system. So digestive system is a tube organ. So starting with mouth, gullet, stomach, small intestine, big intestine, and then anus, isn't it? So this is a tube organ. The next one. Additionally, you have a reproductive system in the small area, in the pelvic area. And then next one, you have got urine system. And then those 3 systems are there in a really small pelvic area. And then digestive system is the next one, is full of germ. So basically, this is from this pipe organ with starting from the mouth to the anus. It's all full of germ. And then urine system is free from germ because this urine system starts from the artery. So it's all clean until it gets to the outside world. And then those 3 systems, and then reproductive system is semi-clean, only good bacteria there. And then those 3 systems, this is a women's body, pelvic area. Those 3 systems meet together in a very small area, genital area, once it comes outside. That's where the bacteria from the anus to the urethra get there and they get urine infection. Next one. So this is a male body and the female body. You can see clearly from the female, from the anus to the vagina and the urethra, it's such a tiny area, and then they always never be dry, isn't it? So it's very difficult to prevent. So women is always have a risk with or without PKD. And the male, look at this, the anus to the urethra is a really long journey for the bacteria to come to travel. And also it's really dry around there. So if men has got the urine infection a lot, there is another problem, so urological problems. You have to really look into that by the doctor. Next one. So if the male with PKD has got urine infection a lot, usually enlarged prostate is a problem, or some stone there, or some bladder problem there, or maybe if you are young, sexual transmitted disease there. So that is really to look into it. So men with UTI is a different world from UTI in women. Next one. Sorry, this is again and again. So women with ADPKD, women is always have a risk, and the bacteria from the anus can easily get to the urethra. Next one. And also other factors to contribute UTI is, next one, diabetes. Next one. So when you have a diabetes, the sugar in the urine, so for bacteria, it's nutrition for them. So you have to really have a good control of diabetes. And if you're dehydrated, next one, and the urine stagnant, isn't it, in the bladder for a long time. So not enough frequency of urination means it's stagnant urine. And if it's stagnant urine, bacteria can thrive there. Next slide. Yeah, voiding problems. So when you become menopausal, women, again, men as well, you can't empty the bladder nicely as it used to be. So next one. and not properly flush the urinary system. You don't have to flush the urinary system every 1 hour, but every 5 hours at least, you really want to empty the bladder completely. So stagnant urine in the bladder is really dangerous for UTI. Next one. And the kidney stone. So kidney stone is another topic, but general population have got 5% of kidney stone. And a PKD patient is thought to be have kidney stone in 5%. Not much difference, but if you have a kidney stone, it's really tricky because kidney stone can be nest for the bacteria to thrive. So you have to talk to a doctor. So this is an image. I quite like images because if I show it to patients, they always kind of get it. So this is a cross section, and this is we are looking at your body from the bottom, and the patient is lying on the back. So you can see on the left two pictures, you can see quite calcified area, bulky one. That is a stone. Yeah. And then, yeah. So, but the other one, quite, how do you say, linear calcified area is not necessarily stone. When the cyst bleed, when the cyst bleeds and then the cyst, try to be healed, they calcified. So in that case, quite linear like this. So can you click? I put click on the slide. Yeah, those are stone, and then those are the not stone. So if you have a stone, you will have a quite risk for the urine infection, but only 5%. So it's quite minor number of people have got stone. Yeah, next one. And also this is again cross section. We are looking at the body from the bottom, and you are lying on your back. Those two are kidneys with cyst. You can see the cyst dark dot. So that cyst can really suppress, push the ureter tube, so that stagnant urine can happen easily if you have a quite big cyst. So that is another predisposition for the patient to get an infection easily. Next one. So I want to just prevent UTI, and then you can really prevent the UTI based on the anatomy. So next one. So prevention is everything. This first step of prevention is a gold standard. And so very common sense, drink plenty of water and urinate fully when you urinate, ensuring you empty the bladder completely. If you have diabetes, good glucose control is important, like I said. And your doctor will check if kidney stones are the source of your infection. Sometimes you have a urine infection, and if your bacteria is always Klebsiella, you might want to check if you don't have a stone, and that is a source. That's not the source. And if you are men, addressing any prostate problem or urination problem are important. Next line. And the woman has a lot. Like I said, can you click next time? Next one. Yeah, so this is the urine, woman's anatomy. So genital hygiene is very important. For instance, wiping from front to back when you use the toilet, or maybe don't use the same tissue when you have a poo, and avoiding using scented washes, wipes, or flannels, and use a clean, only unscented disposable wipe or tissue. And then for sexually active women, this is very important. Urinate after intercourse, and also wash and avoid using diaphragm or spermicide contraceptive, because that is disrupt the vagina's acidic environment and also good bacteria. Other one is over-the-counter products. So there's limited evidence, but some women find it useful. So you can try, but if you are on warfarin, be careful not to use cranberry tablets. Next one. And then if the first step failed, next step it's going to be not so ideal, but better than having a UTI. So next one. So if you have urine infection more than twice over half a year, or more than 3 times over a year, but not more than once a month, you can maybe talk to GP or kidney doctor, standby self-start course of antibiotics based on your past urine culture may be a good idea. So urine culture is very important. And if you agreed with your doctor and if you have a standby antibiotics, and if you develop this urea, you want to take it, but before taking the antibiotics, make sure you submit urine culture, because in case within 48 hours, if the antibiotics doesn't work, you shouldn't keep going, and you have to have to check what's bacteria causing this. Right, next one. And also, again, for women, one of antibiotics after sexual intercourse, if your UTI is always mainly happening after sexual intercourse, may be a good idea. And your doctor will consider maybe vaginal estrogen if you are menopausal. Like I said, estrogen try to keep the vagina's pH low, but if estrogen gone, the vagina become quite alkalotic, and that can help the bacteria thrive from the bacteria from the anus. Next one. So, and then if you have more UTI more than once a month, maybe a 6 month trial of continuous low dose prophylactic antibiotics might work. So you have to really have a plan if the first step failed. Next one. So yeah, so urine culture and urine forms, you always have to have that at home together with antibiotics, standby if you decided to do that. Yeah, next one. Yeah, urine culture before antibiotics. So if the first, second prevention failed, you need a treatment. So UTI only, both cyst and UTI, cyst only. Next, click on that. So like I said, those are quite difficult to differentiate. So you have a sudden pain, and a spike in temperature. You never know if you're PKD patients, maybe UTI only, maybe system involved. So next one. So we have to cover everything first. So sudden abdominal pain and a spike in temperature, you go to A&E. And if you have a blood test, high inflammatory marker, so we always check CRP, usually more than 100, 200, quite high. And without having any other signs of infection, like a chest infection, usually if you're a patient with PKD, we have to cover cyst infection. So we have to think about cyst involved. Start antibiotic early and for a long time, not like 2 weeks. If it's UTI only, 2 weeks is enough. But if it's cyst involved, you need more than 4 weeks. Depends on how well you cleared up. So diagnosis is very tricky, and I'm going to come on to that. And infection, clearing up the infection is very tricky. That's why you need longer term. And usually fluoroquinolone, so ciprofloxacin is a quite good antibiotics, okay to use for end-stage kidney disease as well. And trimethoprim, it's a little bit tricky if your eGFR become less than 30. Yeah, okay, next one. So this is CT of the PKD patients with cyst infection. If you can see, so this is a cross section. You can see the patients. This CT scan looking at the patient from the bottom, and the patient lie on the back. You can see the right kidney bit. Can I see? I can't point out. Yeah, this one. You can see clearly the wall of the cyst is quite enhanced, isn't it? So that is a sign of a cyst infection, but it's never be that clear. This is really clear. That's why I chose this patient. If that happens, we can give antibiotics, also aspirate the cyst fluids to grow culture. That is a gold standard, but it's never be easy to get this level, right? Next one. So this one is a very difficult case, 50-year-old male with ADPKD, and he reached end-stage kidney disease in February 2023, so almost 2 years ago. And then because his kidney is so big, usually 10 centimeter in diameter, the kidney, but his kidney is 30 centimeter both sides. So he had both kidney removed because he reached end-stage kidney disease. And then at this point, he started dialysis. But since then, he had a spike in temperature, one after another. And firstly, he was suspected TB, tuberculosis, and treated for 6 months And then while he was taking the antibiotics, that's okay. But after he stopped taking this, again spiking temperature, and then he is in and out, always infection, chest infection, and gallbladder infection. But actually, that was cyst infection in the liver, but we couldn't detect by the CT scan, MRI, PET-CT. Usually PET-CT is recommended, but it's very difficult to get the timely manner. But even with that, 80% sensitivity, but 20% we miss, like in this case. He has got lots of CT scan, but then April 2024, this CT scan done, retrospectively, maybe you can see a little bit cyst on the right side of the liver is maybe cyst infection. Then next one. Next, yeah. So June 2024, suddenly gas emerged. You can see the gas up. Yeah, the gas, the dark, and yeah. So that emerged. So that means this is a gas produced by the bacteria. Then, can you click? We finally diagnosed with 100% confidence. So they aspirated the cyst and that grow culture, bacteria. But after intensive IV antibiotics, we couldn't get rid of the infection. So finally, next one. Yeah, this is January 2025. He had open left hepatectomy. That's the only way we can get rid of the infection, this infection. And then now, so July 20, so now November and December, isn't it? So it took almost 2 years to get rid of this because it's going to be invasive procedure. We really want to do medically as much as possible, but we couldn't get rid of it. So he had an open left hepatectomy, liver resected, and also gallbladder resected. That wasn't gallbladder infection in the first place. So because we remember PKD is a rare condition and cyst infection is still rare. So if the A&E doctors see these pain and the spiking temperature, we think one of 3 main infection, which is lung infection, chest infection, or gallbladder infection, or UTI. But that actually cyst infection. It's very, very tricky. And yeah, diagnosis is very tricky, treatment is very tricky, but now he's at last can be on a transplant list. Right, okay, next one. So another invasive management, so yeah, next one. If you have this big cyst, can cause infection, you can aspirate it and then you can treat it and you can be treated, cured. Next one. Yeah, aspirated and then that's it. But never be that simple. Next one. So this patient is a massive cyst in the liver together with cyst in the kidney. And the cyst in the liver is very rare. I got 400 patients in my clinic, and in the last 4 or 5 years, only 5 people have got this level, cyst in the liver. But he couldn't eat anymore because of the cyst in the liver. It's so bulky. So he had liver transplant after long discussions or the MDT decision. And can you click on that? And after that, he started to have a numerous cyst infection, UTI, because immunosuppression might sometimes cause more infection because we artificially immunosuppressing the patient. So the immune system is not good enough to get rid of it, get rid of the bacteria. Good for the transplanted organ, but not necessarily overall health. So next slide. So yeah, he's got repeated UTI, end up in left kidney nephrectomy, and now preparing for kidney transplant now. But we can't get rid of infection. This one, the last one, is a woman. You can see quite disproportionate kidneys. So left kidney is quite big, right kidney is quite small, but left kidney is so much trouble. Pain and infection, and the infection becomes difficult to treat because the bacteria become quite wise and become quite super bug. So we know by nuclear medicine images, we know the right kidney, very behaved kidney, has got 80% of her kidney, whole kidney function, usually 50%, 50%. But in this particular patient, PKD patient, but quite disproportionate, the trouble one didn't contribute too much of her kidney function. So we, after long discussion, decided to remove left kidney. The next one, so this is the kidney function. She has got a 20% mils per minute, but after the left kidney removed, only 16 mils per minute. So we know right kidney is a good one and a no trouble one, and that kind of worked, but quite invasive, isn't it? Yeah, so we want to really treat medically, but if it doesn't work, sometimes you need invasive management. Next one. So this is last slide, I think. So treatment, this is a summary. If you have acute abdominal pain, it's sometimes one person said, I thought somebody punched me. So that kind of pain, and also spike in temperature, usually 38.5. This might be, and if you are PKD patient, it might be cyst infection. We have to cover the cyst infection. So cyst or not is very important, but it's very difficult to differentiate, like I said. So upper UTI, only UTI without cyst infection, ciprofloxacin for 2 weeks, usually enough if it starts antibiotics quite quick enough. So you have to really talk to your doctor to have standby antibiotics if you have a lot of UTI. Now, if cyst involved, you need a longer course. So because we can't tell difference easily, maybe 4 weeks course is reasonable measure. And if you have a cyst, culprit cyst causing this cyst infection, and if it's more than 5 centimeter in diameter, we can sometimes pectin drainage. That's it. So you have to have a control. You have to understand your, infection. Where does it come from? And if you can control, maybe you can guide the doctor. So next one. This is the last one. I have got I created this patient information leaflet. If you want it, maybe you can hand over to GP to have a discussion. So that's it. That's my slides, I think.
Thank you so much for a very informative presentation there. And I can see the detail that went into it in preparation with all those images. Thank you. I don't think I'm the best doctor to try and find the cyst or the calcification.
Yeah,
so
trouble. Yeah, such a trouble. Yeah.
Yeah. Now we'll move over to the Q&A. And as I said earlier, you'll see a little icon in the bottom of your screens, depending on your device. It may be at the top, and you can pop anything in there. Alison, have you been keeping a little eye for questions coming in?
I have, yes. Somebody's asked, or a couple of people have asked really, that they've been presenting with a lot of pain that continues for up to 2 weeks, but no fever or culture that always seems negative. But the doctors are giving them antibiotics. Is that as a precaution to treat that?
So yeah, it's a really good question. I put the slide something, but I didn't read that. So pain without spiking temperature, without immunosuppressants, if you're not immunosuppressed patients, transplant patients, and if your EGFR is still like more than 30-ish, you should have a spike in temperature. So if you don't have a spike in temperature, like you said, it's not likely to be infection. So only pain control is the most important. And yeah, so the pain is nothing to do with infection. You can't have without any temperature for 2 weeks. So that's the quite tricky bit.
Yeah. Somebody else has asked, is there any benefit to managing gut health in reducing recurrent cyst infections?
Very good question. So cyst infection, like I said, without UTI, only cyst infection, we don't know how does the bacteria come from. Usually we think from gut. So gut bacteria translocation. So we think maybe, like try to have a healthy gut bacteria would be good. So there's some evidence, but evidence is high enough, not high enough yet. So the guideline said maybe polymyxin, neomycin combination might be good, but we don't recommend it because we don't have much evidence. And then remember, always antibiotics has a risk. You might develop resistance. That is going to be bad. So less antibiotic exposure, definitely better. So still, we are waiting for the evidence.
And just when you use the word risk, someone's saying they understand that is the drainage of a cyst is also a risk of introducing infection.
Yes, yes.
Is it worth the risk of having it drained?
True, true. So we don't recommend it if, start antibiotics, IV, and within 48 hours, there is no sign of, improvement, and we know there's a big infected cyst, then maybe, or if you're immunosuppressed, maybe better to drain because the bacteria having a party in the cyst. It's very difficult to treat only IV. So yeah, and then actually, when I show the first kind of cyst infection, that cyst high intensity wall cyst infection, that happened after cyst drainage. So you have to be really careful. Invasive procedure, you have to weigh up the balance. You have to, benefits much outweigh the risk, isn't it? So it's good point. Thank you.
Somebody else has asked, perhaps back to the risk sort of ask, really, are CT scans safe to have because of the use of dyes?
Yes.
What are the issues to do with that?
It's not good. So the last patient I showed you, it's a 2-year journey, she has got every week CT scan with contrast CT scan because it's easy. So doctor is human, isn't it? Rather than chest X-ray or abdominal X-ray, we love somehow CT scan, and then CT scan kind of show everything to us. Somehow we have a kind of pseudo kind of perfect control feeling, but actually not. So we really have to be careful. But somehow we go into more technology parts, isn't it? As leaving patients behind. It's a very important point. You shouldn't have that CT scan easily.
Susan.
Yeah, when it's caught my eye when we're talking about imaging there is the size of cysts. And someone's asked, if my cysts are too big, can they be drained to avoid them bursting?
Bursting.
So
the patient is asking the risk of bursting?
And could they maybe be drained so they don't burst?
Yeah, it's really, I often come across this question in my patients. Yeah, definitely physically, if it's 10 centimeter big, and if you're a woman, not so much, protection of muscle. It's a kind of fearful, isn't it? But it's actually, our body is quite guarded by the rib cage and also muscle and the tissue. And if you are not rugby player, not so common to have a rupture spontaneously. Of course, if the cyst is bigger, the more the risk. But fortunately, quite rare, unless you have a fall, completely fall, and then to get to the landed of the big cyst. Usually, it doesn't spontaneously rupture, luckily.
Yeah, and I know earlier you spoke about some of the causes of infection, but someone's asking what causes the infection on the kidney, and can the cyst get infected for the kidney to bleed?
You mean infection, kidney infection?
Yeah, so they're trying to understand how it actually travels up into the kidney and gets those cysts too, I think.
Yeah, so kidney infection means UTI or cyst, nothing else. Yeah. So if the cyst communicate to the ureter, cyst infection can cause UTI ultimately. And if UTI can cause cyst infection, but if cyst is not communicated, only cyst infection, that's it, isn't it? Does that make sense?
Yes, it makes perfect sense when we slow it down and we think of the connection between the two.
But many A&E doctors somehow didn't get it. So people think, yeah, definitely this is a pyelonephritis. They don't think an isolated cyst infection exists. So they think this is pyelonephritis, but urine culture doesn't show anything. Urine dip doesn't show anything. It's very strange that, and they think, oh, maybe gallbladder infection. Maybe, but if the patient is a PKD patient and a big cyst there and a quite big pain, much pain and the temperature, you need to think about cyst infection, but it doesn't occur to them because like I said, PKD is a rare condition and cyst infection is rare in the rare. That's what you have to understand.
Before I move over to Alison, there's one that's caught my eye there, and it's just a continuation. If you had that infection, could it damage your kidney?
So infection itself, if it's a bladder infection, it's not going to cause trouble, right? But if bladder infection develop to sepsis, sepsis is a systemic response. So sepsis always a risk of AKI, regardless of PKD or PKD not. But if your PKD patient has got reduced kidney function already, AKI is quite a big toll, isn't it? So acute kidney injury, sepsis always, the risk of AKI, acute kidney injury, yes, that can damage the kidney. But the sepsis or urine infection, if you treat really quickly, the damage doesn't last long, right? So the shorter the damage, better recovery if you have damaged the kidney function, and also depends on how robust your kidney was originally. And usually if you have an acute kidney injury, the recovery is not perfect. So usually partial recover. So you have to really control infection quickly.
Somebody's asked, and sort of reflecting back, that in the 80s, in the 1980s, their mum was sort of permanently on urinary antiseptic methenamine. Is this ever used nowadays? Have you heard of that? Is that something that's used?
So methenamine hiprate? No. Methenamine hiprate. If it's a methenamine hiprate, it's a quite new thing.
Oh, this is 1980s, so I doubt that. So
is that tablet?
Urinary antiseptic methenamine. The person who's sent that, could you just send another question and just sort of let us know if that is the right compound?
So when I touched on about the 6 months course of prophylaxis, if you're a woman, nice recommended first line is methenamine hiprate. So maybe it's related to chemical.
Okay, yeah.
Wise. So methenamine hiprate, we call it Hiprex. It's off license, but a nice recommended it. It's quite always a discrepancy there. Nice NHS recommended it, but actually they don't fund it. So discrepancy there. So you can get over the counter, but many GPs agreed to give prophylactic methenamine hiprate. This is a prophylaxis. So prophylaxis treatment is different. If you have,
can you just explain what prophylaxis means? Is that okay?
Prevention, sorry, prophylaxis is prevention. So I said first prevention, second prevention, but with those failed treatments, if you die, full-blown UTI, you can't continue prophylaxis. I mean prevention. Prevention, low dose of antibiotics. So, for example, if you try trimethoprim, usually you need one tablet twice a day, but prophylaxis usually 1 tablet at night. That kind of thing.
Okay. So, and the gentleman has come back and said that the brand name was Mendelamine of whatever product it was he was talking about. So, but I think we've covered that. So that's really great. Okay. Somebody's asked, following what you were saying just previously. So if somebody's got a cyst infection, and is it better to contact the renal team rather than to go to A&E? They're asking what an AKI is, which I know is an acute kidney injury, but is it better to go to the renal team than go to A&E?
This is very tricky. So I got, like I said, 400 patients, and if the patients have got a spike in temperature and the pain, I definitely think this is acute cyst infection. So I just gonna ask them to come to RAU, renal assessment unit. We got a renal assessment unit with the big hospital. You should have that. So kidney A&E, so renal A&E. So they have to go to renal A&E. But the sad thing is, any A&Es are flooded with patients. So that's why prevention is the most important. So you have to talk to maybe nephrologist to show maybe the patient leaflet, and I'm having this constant infection. I need to have some control. And yeah, so that's conversation needed to happen. But the thing is, reality is not many people know about this. Even kids
Yeah.
don't know. So very difficult. It depends on how good kidney doctor there. If that person there, great. But if not, you have to really push anyone. So nowadays, day treatment center or pharmacist, you can get the antibiotics, right? But if you have a spike in temperature, you can't just leave it like antibiotics. But usually when you take it, the antibiotics, as soon as possible, 50% chance you can treat it with oral antibiotics, but you need a longer course.
That is a perfect thing to bring in a question that I see there in the chat. And it's someone, if you have intense kidney pain, a spiking temperature, no blood in the urine initially, should you assume it's a cyst infection and have IV or oral antibiotics? Is that enough?
Yeah, so very good question. If you have that already, antibiotics at home, I always ask, dispense patients with cyst infection in the past, I always give them. So when you have that at home, and if you have that spike in temperature, as soon as you have that symptoms, if you can take that, so I would say 50% chance oral only is okay. So you don't have to come to A&E, you don't have to be admitted. As soon as possible. The speed is very important. Any sepsis, any infection, quickly.
Just before we go to one that's been asked by someone on dialysis, if anyone has any further questions, please pop them in the chat. We have another few moments that I'm sure that Yuki will be able to answer. If you pop them in there, we'll get them asked. Someone's asking, does anything mentioned so far differ for anyone who's on dialysis?
Sorry, I couldn't catch.
What we've spoken about tonight, infections, infection control and treatment, does it differ at all for those in dialysis?
Does it death? Sorry.
Differ. Is it different? So if you had a
Different.
would we treat them differently?
Same, basically same. So dialysis patient is the same weak immune system as transplant patients. So your infection get more severe and longer. So yeah, definitely the same things apply, but more quickly and longer. And you might need IV. But the most important thing is dialysis patient, hemodialysis patient especially, you come into the dialysis center 3 times a week, right? We can give you IV in an extreme case 3 times a week. There is IV antibiotics 3 times a week is enough. So yeah, you have to talk to your renal doctor about this because you don't want to be admitted unnecessarily. Yeah.
Right. And one little question that's still sitting there, because we have spoken about cysts bursting. When a cyst bursts, effectively, how does it heal? Does it grow another skin?
Okay, so it's a very important question. Cyst burst, if this cyst is not infected, it's just burst, and then fluid, like a urine fluid, coming out of the abdomen cavity, right? Abdominal cavity. It's maybe a little bit pain, but that's it. Usually body absorb the fluid quite quickly, kind of over a month or so, but you have a pain, right? But if this cyst infected, burst, that is disaster, isn't it? So you're going to have a temperature. So always temperature. If you have an general immune system, you have a temperature. If you haven't got temperature, burst, just pain, basically. Quite irritable chemical, feeling inside, but not necessarily medically really life-threatening.
And we've mentioned those that are post-transplant. And someone's asking, are you less likely to have a cyst infection post-transplant?
Very good question. So immunosuppression-wise, you tend to get more infection, like I said, right? Because we artificially immunosuppress you. So good for the kidney, but bad for the other infection side of it. But interestingly, when you have a successful transplant, your cysts tend to shrink because uremia gone. We don't know why, and then not everyone, but up to 80% of transplant patients, cyst is really shrink. So the infection risk gonna go down with the decrease in size. So it's a net profit. We don't know which is which. It all depends on the patient's shrinking size, or maybe immunosuppressants, more determinant factor. So quite divided. Yes.
Dr. Heath, can I just ask? Somebody said that they saw on your slide the info sheet that you'd created. Is that something you might be willing to share with us that we could pass
Yeah.
on to people?
Definitely. That's why I created it. So
Great.
the PKD Charity, if you can just put it.
We can.
Yes.
If you let us have that, we will make sure that goes out with the follow-up details following this
Yeah.
session.
Only,
So
yeah.
thank you.
Yeah. A4 back and back and how to say.
It's great. If
Yeah,
you
so
just
one
email
page.
it to us, we'll get that sorted. Thank you very much.
Yeah.
So you need it. You have to guide.
Yes, we
Yeah.
have to educate our GPs. They
Because
always need educating.
yeah, PKD is a rare condition.
Yeah.
Only less than 1 out of 2,000 people. So yeah, GP don't know.
No.
Others
No.
might not know.
Right, we've got a few minutes to go and we've got a slightly off topic, but it is cysts and it's relating to liver cysts, and we did hit on them earlier. Someone's asking, is it a week worth of antibiotics long enough for a liver cyst infection, or would that very much depend on the patient?
Yeah, so this is a very good question. So cyst in the liver, cyst infection, kidney or liver, definitely same, basically. And we don't know why cyst in the liver get the infection, like a cyst, isolated cyst infection in kidney. So we think via blood, we think via, again, gut bacterial translocation. So maybe gut health may be important, but we haven't got enough evidence. And liver cyst infection is tend to be severe than cyst infection in the kidney. And you need usually IV straight away, not oral. Kidney cyst infection, maybe we can do with it oral, but cyst liver infection, you need usually 2 kinds of IV. So you really have to go to A&E, unfortunately, and a longer course, definitely more than 4 weeks. So there's a guideline, 2020, so this year, KDIGO published quite good one. If you can have a look, they said that same thing. Very good question, yeah.
And the biggest takeaway for our audience tonight, UK, would that be just to try and flush out the bladder to avoid? So it's prevention would be the key thing.
So apart from isolated cyst infection, it's usually almost always come from the anus, bacteria from the anus to the urethra and to the bladder, to the tube, and then kidney. This is usually, that is the normal course. So we have to prevent the bacteria from the anus to get to the urethra. Yeah, so I think by half we can prevent it, maybe more. There is no evidence. There's no research on that. But yeah, it's obvious anatomy, isn't it?
Yeah, I was very fortunate. We had an information down in Birmingham and I sat in one of your workshops, and you did recommend for the ladies about double voiding when we go for a wee.
Yes.
For those in the audience that don't know what that is, do you want to explain it to them, please?
Yeah. So yeah, when you become menopausal, like I said, tube organ never be effective enough like used to be. Everything, isn't it? It becomes slow. So when you think you finish urinating, but usually 100 mils of urine still there. It never used to be, but still there. So 5 more seconds, give it 5 more seconds to squeeze your bladder out, and you're gonna be surprised. There's a little bit more, and maybe changing posture to try to squeeze the urine out is very important. Give just only 5 seconds. And also, if you can, when you wee, stop the wee in the middle. 10 seconds so that you can, strengthen the bladder, like a bladder training. You don't have to do extra thing, but every time you go to wee, give 15 another extra seconds, 10 seconds, stop the wee to strengthen the bladder's, how do you say, muscle. And also on completion of weeing, give 5 more seconds to wee completely. That is double voiding.
Double
No.
voiding.
And for many, it can be a magic cure or prevention. So it's just
Yeah,
good advice to
constantly you
have.
have to do that. Yeah, you have to train in a daily lives. You don't have to do extra thing, but sustainably longer, because we always become, loosen. All the muscle become loosen, skin become loosen, inside outside. Yeah, so let's fight against aging.
Alison, do you want to pick a final question perhaps out of the couple that are left there, please?
Well, everybody's asking questions now.
Yeah.
I'm just trying to find one that's completely on topic.
If you want to have a read through of the new ones that have come in, I'm going to go to
Yeah.
one. How can you tell the difference between a kidney or a liver cyst infection? I take it that's for a patient. How can we tell what's happening if it's coming from our liver or our
Very
kidney?
good question. Because quite difficult if you have a big cyst in the kidney and a big cyst in the liver. How can you differentiate? We don't know.
Mhm.
And it's not much of a problem to differentiate. You don't have to do that because you need antibiotics. Maybe if your cyst in the liver quite big, let's think about the worst scenario case. So cystic liver infection. So in that case, you have to go to A&E to get IV antibiotics straight away.
One last question. Somebody's asked, at what age in this journey with PKD does a cyst infection or rupture potentially happen? Like in that trajectory, have we looked at your brilliant, we looked at a map of sort of what happens. What sort of age will that will this start to become an issue with somebody who's got PKD?
This is really so as a rule of thumb, the bigger the cyst, the bigger the risk of infection.
Okay.
So usually late 30s, the cyst become more kind of visible. So late 30s. But yeah, so late 30s, yeah, and the 40s onwards, immune system
Okay.
goes down with aging. Yeah, cyst becoming big and the kidney function going down, unless you have a successful transplant. It's a bigger and bigger, isn't it?
Yeah.
Mm.
That's great. Thank you so much, Yuki. You've answered lots of questions. Your presentation was great. And it's been really lovely to have you with us this evening to answer things really straightforwardly and to give really practical advice. Prevention is the key.
Yeah, hopefully prevent more than half from now on.
Okay.
Yeah.